Hello and welcome to today's Here's to Your Health podcast. I'm your host, Don Lintzman. My guest on the podcast today is Dr. Richard Malyszek, more lovingly known as Dr. Rick, here at CCMH. And Dr. Rick, thank you for joining me today.
Thank you. Thanks for inviting.
Dr. Rick is a relatively new addition to the medical staff here at CCMH. He's a general surgeon. And before we start talking about the topic we really want to discuss today, which is colorectal cancer, tell us a little bit about yourself and a little bit about your background.
Okay. Yeah, I grew up in Scranton, Pennsylvania, which is considered near the Pocono Mountains. So grew up there after finishing high school. I went to college, started at the University of Miami down in Florida, and then did my graduate work in medical school at Hannum University, which is in Philadelphia, which is now called Drexel University. From there, I did my residency at part of the University of Pennsylvania System Graduate Hospital, which was part of the University of Pennsylvania, and was in the reserves through my surgery training, and then was fulfilling some of my reserve time when 9/11 happened, and then became active duty and was a combat surgeon in what we call Forward Surgical Team, a team that we actually jumped into the war. We didn't during the Iraq War, but it was kind of what we call a FAST team, which is Forward Surgical Team. It was life, limb, or eyesight, kind of like a MASH unit, if you watch the TV show MASH. And did my 4 years there, came out as lieutenant colonel, and then been in private practice since then.
So tell us a little bit about your experience as a general surgeon outside of the military. You've had a couple of other stops.
Yeah, so I was in Colorado in sole practice, the only surgeon in a hospital by myself for probably 13, 14 years, on call 24/7, which is good. It kind of grounded me, because I was raising two boys, and then was there for a number of years, then became an acute care surgeon, which was a surgeon that sort of goes between, I was covering 3 different hospitals. Any of the emergencies I came in, from the trauma to the gallbladder and appendix, I would take care of it for a larger group. And then was recently in Valentine, Nebraska for 4 years doing general surgery, only general surgeon, really, really small town. And recently became empty nesters, or our boys that are off to college, and some have completed it. And me and my wife just saying, hey, why are we living apart? So we picked a town that was a little bigger than Valentine. And do you like this town? I said, okay, let me see if I can get a job there. So so here I am.
Seems fair.
Yeah.
My guest on the podcast today is Dr. Rick. He's a general surgeon here at CCMH. And now we're going to start talking about colorectal cancer awareness, because March is Colorectal Cancer Awareness Month. So let's just talk about colorectal cancer as a disease to begin with.
So in 2024, there was 106,000 new diagnoses of colorectal cancer. And also in 2024, there was 46,000 people succumbed to disease. I guess better word is they died from it. Now, I don't want you to take away that, well, it seems like half the people that got it passed away. That was all people who were diagnosed 2, 3, 4, 5 years ago that, succumbed to it. So it's the number 2 leading cause of cancer death in the United States, but it's preventable. Lung cancer, people still get it. You don't have to be a smoker to get lung cancer. Lung cancer, number 1 cause of cancer death. Smoking, secondhand smoke, or radon, which when I grew up in Colorado, they have that problem. So you can get it for a lot of reasons. Colon cancer, we can actually prevent it. If we do colonoscopy like we should, when we should, we can remove the precancerous growths, we call them polyps, and get those removed from the colon during the procedure, and then they can't turn into cancer. And of the people who get diagnosed having colon cancer, if caught early, which means it's still within the colon itself, hasn't spread anywhere, or the rectum, about 91% of those people will be cured with surgery.
The one thing that we've talked about is that colorectal cancer is somewhat tied back to genetics, but not a ton.
Yep.
And so I guess maybe the question is, do we really know what causes it, or is there any one cause for colorectal cancer?
I would say there's one cause. If you have, there are some family histories that accounts for about a little less than 10%. There's something called FAP, familial adenomatous polyposis. There's some syndromes that if you have it, your chance of getting colon cancer by the age of 30 is almost 100%. But that's, I wouldn't say rare, but it's not the common. It's probably diet and lifestyle, like most things in this world. I know we're Americans, we don't like to hear that. We don't want to change what we're doing. Just give me a pill.
Those two dirty words, diet and exercise.
Yeah, so, which does a lot, and you'd be amazed. And unfortunately, we're a society of overweightness, increased BMI, as we say nowadays, to be politically correct. And being overweight and obesity has a lot to do with a lot of female cancers and even colon cancer. So, eating a good, healthy diet, eating fiber. I know a good friend of mine is a colorectal surgeon. He's got a terrible last name. His last name's Butcher. But, every time we just don't get enough fiber.
There is a procedure you can go through, legal procedure to change your name, but I guess you decided not to do that.
It stuck. And so, diet, you get enough fiber in our diet. Things like that. It's just being healthier and diet and exercise, but smoking, alcohol, certain medications. There are people who have inflammatory bowel disease can have an increased risk. So, it's just being a little better to yourself.
What about symptoms? I mean, most of the time, what ends up happening is that people really don't pay much attention to any of these things, any of the illnesses that they have, until they have symptoms. And I think that's where a lot of people land with illnesses. That once I get symptoms, then I'm going to go do something. But I think hearing you talk about it today, if you have symptoms, it's probably too late.
It can be far along. So the symptom that gets everybody's attention is when you go to the bathroom, blood. Okay, that's it doesn't take much. 3 drops of blood can make a whole total red. So that's a scary finding. But changes in bowel habits, a lot of times we find it. The reason why the doctor gets blood work every year, sometimes it gets picked up by people being anemic. And then we go, you can lose about a teaspoon of blood in your digestive system. Not enough that you're going to notice, and become anemic. Iron deficient anemia is the one that we kind of tag along with that, and you can become anemic, and we go do the colonoscopy because you can leak a little bit of blood to your digestive system without you knowing, and sometimes we find colon cancers that way.
My guest on the podcast today is Dr. Rick, general surgeon here at CCMH. We're talking about colorectal cancer awareness because March is Colorectal Cancer Awareness Month. So we've also talked a little bit about colonoscopy and who's a prime candidate for that, and exactly what the procedures are in order to be able to get that accomplished. So let's talk about colonoscopy for a minute.
Yeah, so we used to, so the incidence of colon cancer peaks around the age of 66. So we tend to, we think, we don't leave polyps behind to see what happens, but we think it takes a polyp maybe 7 to 10 years from a polyp to a colon cancer. So if the incidence is really high at 66, we're going to start doing stuff in our 50s. What is happening in our universe, not sure all the reasons why, but the younger population is becoming a little more affected earlier. So we've changed average risk screening. Average risk screening is, I don't have a family member who has colon cancer. I don't have blood in my stools. I don't have anemia. All that is just average risk screening. We start at the age of 45 now. If you have somebody in your family who had polyps at 40, we would look at you and you're a first-degree relative, so somebody that shares half your genes, mom, dad, sister, brother. We would start looking at you 10 years before that point. So average risk screening, age of 45. If you have a family member, we would see increased risk. If you have a family member under the age of 55 to 50, then had colon cancer, we would consider you increased risk. And we would start 10 years before they had it found.
So let's talk about the box product that you can get in the mail.
Yeah.
I think the brand name is Cologuard.
Yeah.
How does that work? Is it reliable? Should we be asking our medical provider, to give us a prescription for that?
Yeah. So if there's just some reason you can't, the colonoscopy is the gold standard. Reason being, the Cologuard has its limits, and it may only pick up polyps of a pretty good size. It may not pick up the smaller ones. So the Cologuard doesn't remove the polyps. It just says at this point in time, your risk is high or low. So we call it a very sensitive test. The test that's going to be positive, we have something wrong with you. Whenever we have a screening test like the Cologuard, you always see the guys walking down the street and his colon's walking next to him, having a good time, drinking a soda. The Cologuard test was going to err on being overcalling things. Now you're like, well, you doctors, you guys always want to find something. No, we just want to find something that make be your demise, and we want to find it early. So it can have an increased false positive rate, but you kind of want that in society. You don't want to miss anybody. So that test looks for the DNA and also looks for blood in your stool. And it can be positive, but it's going to be over positive. Say you ate and I'm not sure if this is exact, but say one reason some of the other tests used to be false positive, if you ate a pretty rare steak the night before, because blood is blood, right?
Right.
So, or if you drink too much vitamin C and
Sure.
some other things, it would look for something called oxidizing agents. But anyway, so that test can overcall. Now some people say, well, I'll take the test, but if it's positive, I'm not going to do anything. Well, that's not really the right mindset. If you weren't going to do anything, if it's positive or negative, you still weren't going to do anything. You've kind of just wasted probably $600. And so, if you're going to go down that road and it tests positive, then you need to have the follow-up colonoscopy. And there's some people that can't come off blood thinners. There's some people. There's just a lot of reasons that I just can't have a colonoscopy for whatever reason. It's a still way to screen people.
But it's maybe not the best.
It may be not the best because, and it's not a one and done. A colonoscopy, if I do a colonoscopy and you have and your average risk and you don't have any polyps, you're good for 10 years. The Cologuard needs to be repeated depending on a lot of things, but at a minimum every 3 years and sometimes every year. So it is what it is. But, if you're going to do the test, you have to understand if it is positive, you're going to need colonoscopy, and that, usually an upper and lower endoscopy because blood can come from anywhere in the GI tract.
Well, what about the risks that are associated with any sort of surgical procedure?
Yeah.
Colonoscopy would fall in that category.
Yeah, I mean, me driving here today, I assume some risks to do it. So it's a safe procedure. I looked this up years ago. If you were going to take a vacation, you drove 1,000 miles, the chance of you getting in a fatal car accident is 1 in 333. The chance of having a fatality during colonoscopy is 1 in 1,000. So it's almost safer to get a colonoscopy if you really want to make it elementary like that. But it's within reason. So there are risks, bleeding, injury to colon, but we do what we can to minimize his risk. And everything is, if you think like a teeter-totter and everything, it's risk-benefit. You always do the risk-benefit type thing in your head, and you have to decide, what's best for you. But the thing is, get the information, get all the information. I'm not saying off the internet, but get good, sound information, and then base your judgment on good, sound information, and then you decide what's best for you.
My guest on the podcast is Dr. Richard Malyszek. Dr. Rick, as we know him here at CCMH, general surgeon. We're talking about colorectal cancer, what you can do to both prevent that and what you can do in order to be able to just diagnose it and treat it. For anybody who might be listening to the podcast today, Dr. Rick, and they all of a sudden say to themselves, it sounds like I probably ought to go do that colonoscopy thing. What should they do? What's the next step?
So, good health maintenance is seeing your primary care physician at least once a year. So, they're going to have little things watching out for you and, your family history, what are your risk factors, and they're going to keep you in, if you're doing the right things, they're going to keep you in the fold to make sure you're getting your screenings, and it's a conversation. And, people are busy sometimes, and maybe once in a while, it slips somebody's mind. So it's kind of up to you. So screening used to start at the age of 50. If you've had, it's not a good around the Thanksgiving table to start asking everybody had colon polyps. But, if you have a sister or brother, or a dad or mom.
It is a conversation starter, I would say that, yeah.
If have you ever had polyps? Well, if they did, ask them what age they had them, and then, put that in and bring all that information to us. And, one good thing about being a good primary care physician, and I think we have great ones here, is, a good history and physical and going through that history and, has anybody had polyps? Do you have inflammatory bowel disease? Has anybody had colon cancer? There are some colon cancers that kind of go with a 3-2-1 pattern. I think it's Lynch syndrome, but it kind of skips. It's like all cousins, aunts, uncles, brothers and sisters, and they tend to have more right-sided colon cancers than left. But it's just I know nobody wakes up every morning and it's like, geez, I can't wait to have my colonoscopy today. But it's one of these things that I'd make the joke: if you get it behind you, it's you're done with it. But if you get it done at the right age and they don't find anything, you're good for 10 years, and you can sleep well at night knowing that you're pretty good for 10 years. Now, if somewhere down the line, it's been 7 or 8 years, and you're like, oh, I'm having blood in my stools, or this is happening. Well, it can't be the colonoscopy. I don't like to say this number, but it is being truthful and honest. A colonoscopy, if you take all people that do colonoscopies, there can be a 20% miss rate. Your colon's not a piece of PVC pipe. It has nooks and crannies and tends and burns and stuff like that. But you should be rechecked against. But for the most part, in most hands, it's done safely and it's done accurately, and people do well. So,
what's your biggest takeaway from our discussion today? What's one thing that you want people to know and remember about colon cancer, colonoscopies, anything that we've discussed?
It's not as bad as you thought. It's not as bad as the horror stories that you hear. It's about health maintenance. Would you rather have something that could be prevented? That'd be great. Would you rather have something that could be caught early and you have a 91% cure? And, maybe don't do it for yourself, but do it for your family.
Yeah, absolutely.
So,
for anybody who might be listening today who would like to have a further discussion or try to get in contact with Dr. Rick to talk about perhaps their risk or a little bit more about the procedures that he offers, you can give him a call at the CCMH Medical Clinic at 265-2700.
Yep.
And Dr. Rick, thank you for your time today. Appreciate it very much. I'm sure you will be a frequent guest now on our Here's to Your Health podcast.
That's part about being a doctor. It's just getting the word out and helping people.
And I appreciate that very much.
Thank you.
I'm Don Litzman, your host for the Here's to Your Health podcast. Thank you for listening today, and we'll be back soon. Have a great day.